What I'm about to review changes how you understand what's happening to your face, and the evidence runs through your forearms. There's a thread of connective tissue that starts in your palm, crosses your inner wrist, climbs your forearm, passes your elbow, continues up the anterior chain, and arrives, without interruption, at the periosteum of your zygomatic arch, your cheekbone. One continuous structure, not a collection of separate parts. When you grip a phone, squeeze a steering wheel, carry shopping bags with your palms facing the floor, that thread shortens on one end. The evidence this review examines is the clinical claim that releasing the forearm end, specifically through supination and wrist extension, produces a measurable change at the face end. The stakes of getting this wrong are not trivial. The midface loses structural support when the tissue beneath it is under sustained anterior tension. Not dramatically, not overnight, but over years, the drape of soft tissue over the zygomatic arch shifts. The contours flatten. The lower face appears to descend. These are changes most people attribute to gravity alone, or to age, when in fact, a portion of what's happening is entirely addressable through the mechanics of the arm. This review evaluates the protocol across 4 criteria: mechanism validity, chronic loading consequences, technique precision, and observable outcomes. Then a verdict and a contextual protocol for 3 different populations. Let's begin where every honest review must begin, with whether the underlying anatomy actually supports the claim. Thomas Myers spent years in anatomy laboratories mapping what he documented in anatomy trains, the myofascial meridians, continuous chains of connective tissue that run through the body along specific functional lines. The superficial front line is the chain most relevant here. It runs from the dorsal surface of the toes, up the anterior shin, up the front of the thigh, across the abdomen, up the anterior chest, up the neck through the sternocleidomastoid, and terminates at the scalp fascia. But there is a convergence that receives less attention in the lower limb portion. The anterior arm fascia, running from the palmar aponeurosis through the flexor compartment of the forearm, merging into the anterior chest, joining the cervical fascia, and connecting to the periosteal attachments at the cranial base and midface. Dr. Carla Stecco, anatomist at the University of Padua, and perhaps the most rigorous contemporary researcher of fascial tissue, has documented in cadaveric dissection that these fascial layers are not simply adjacent. They are histologically continuous. The tissue does not stop and restart at joint boundaries the way muscle does. It glides, yes. It has layers that move relative to each other. But the structural thread, the collagen network within it, runs continuously. That finding is the anatomical foundation for everything that follows. The forearm flexor fascia wraps all of it. The bicipital aponeurosis fanning out from the biceps tendon across the flexor compartment, the flexor digitorum superficialis, the pronator teres. These are not separate bags of tissue with gaps between them. They are woven. A single warp and weft of collagen that extends toward the elbow, then toward the shoulder, then cephalad. Woven. That's closer to it than connected. The fascial chain is a textile, not a plumbing system. The distinction matters because in a plumbing system, you can isolate a section and work on it independently. In a textile, tension anywhere propagates everywhere else along the warp direction. That propagation is not metaphorical, it is mechanical. In the same way a coastal root system holds the cliff face in place, pull the root tension and the cliff face shifts. The fascial tension from your forearm is registered at some magnitude at the face end of the chain. Now, the second criterion. What does chronic loading of this chain actually do? Consider the position of the forearm during most of modern daily life. Typing places the forearm in pronation, palms down. Using a smartphone places the forearm in pronation. Gripping a coffee cup, a door handle, a child's hand, a golf club, all of these preferentially load the flexor compartment over the extensor compartment. Pronation is the closed position of the forearm fascial chain. Supination is the open position. Most people spend the overwhelming majority of their waking hours in or near pronation. The consequence is progressive shortening in the anterior compartment, and that's not quite loaded. Progressive loading of the anterior compartment. Shortened implies permanent change in resting length. Loaded describes what's actually happening at the tissue level, which is sustained mechanical tension that hasn't yet produced structural shortening, but is heading there. When the anterior chain is under sustained load, the tension propagates. Not at full force. The dampening that occurs across joints and fascial layers is significant, but enough. Enough to maintain the zygomatic periosteum under low-grade anterior and inferior traction. Enough to alter the resting drape of the soft tissue over the midface. Enough that when you release it, systematically, specifically, there is a perceptible change. This is the question the review turns to now. Does the 90-second forearm unlock specifically address this loading pattern, or does it address something adjacent, and adjacent isn't the same thing? The protocol centers on two movements performed simultaneously: forearm supination and wrist extension. These are not arbitrary. Supination directly reverses the pronation load. It winds the forearm fascial compartment in the opposite direction. The primary muscles involved in pronation are the pronator teres and pronator quadratus. Both have direct fascial connections to the flexor retinaculum and the palmar aponeurosis. When the forearm supinates against gentle resistance or simply to end range, those fascial connections are systematically lengthened. Wrist extension adds the second dimension. Flexor digitorum superficialis, which is the largest of the forearm flexors by mass, is placed under eccentric load when the wrist extends. Its fascial envelope, continuous with the palmar fascia, comes under tension that propagates proximally toward the elbow and then toward the bicipital aponeurosis. Let me come back to the elbow position. Actually, the elbow position should come first because it changes what both of those movements accomplish. When the elbow is extended during supination, the bicipital aponeurosis is placed under stretch through its proximal end. When the elbow is flexed, that proximal tension is released and the load stays distal. The choice between these positions determines how far up the chain the release travels. For someone whose primary tightness is in the forearm itself, elbow flexion is sufficient and often more comfortable. For someone whose tightness extends into the anterior shoulder, and in most chronic patterns it does extend there, elbow extension recruits the chain more fully. 90 seconds, not 60, not 30. The reason for that duration comes from the biophysics of connective tissue. Fascial tissue is thixotropic. It becomes more fluid under sustained mechanical input. Brief loading produces elastic recoil, the tissue bouncing back to its original configuration within seconds. Sustained loading, held beyond approximately 70 seconds in most in vitro studies, begins to produce a genuine change in tissue viscosity that persists after load removal. 90 seconds is the clinical standard. The threshold is approximate, not absolute, but it is evidence-grounded rather than arbitrary. A flash comparison that captures this. Fascial tissue under brief pressure is like river clay touched for a moment. It holds your fingerprint for seconds, then closes. Hold that same pressure for 90 seconds, and the clay around your fingers has reorganized. The river is still moving, but the channel is wider. The third criterion is observable outcomes, and this is where intellectual honesty requires some precision. What changes immediately after the forearm unlock, and what is inferred rather than directly demonstrated? The review distinguishes between these because conflating them is how credible protocols get dismissed alongside implausible ones. What changes immediately? With good evidence, the myofascial tension in the forearm flexor compartment decreases. This is measurable with myotonometry. What follows from that, with reasonable anatomical inference? The tension transmitted up the anterior chain to the cervical fascia decreases proportionally. What follows at the face end, with reasonable inference grounded in Stecco's continuity findings? The periosteal load of the zygomatic region decreases. The zygomatic arch, and this is worth expanding, the soft tissue overlying the zygomatic arch responds to changes in fascial tension below it. The specific finding in a small cohort I'm aware of from rehabilitated facial work suggests that subjects who received forearm fascial release showed measurable changes in mid-face soft tissue position at 30 minutes post-release. That's not the same as randomized controlled trial evidence for rebuilding cheekbone structure. It's a signal worth taking seriously in clinical practice while remaining honest about what the large-scale evidence for the specific facial outcome looks like, which is limited but mechanistically sound. Something happened when I encountered this protocol that changed how I think about anterior chain assessment. I've been reviewing myofascial approaches for a long time, reading Myers, following Stecco's dissection publications, understanding the theoretical framework. And then I tried the supination extension release on myself, not looking for anything in particular, just running through it as I'd run through dozens of other protocols before writing about them. The change I noticed wasn't in my forearm. The forearm felt expected. The familiar release of a tight flexor compartment, the slight warmth of tissue responding to sustained stretch. What I hadn't anticipated was the change I registered in my jaw, a loosening. And that's an imprecise word, but I can't locate a better one. In the masseter region and along the inferior border of the zygomatic arch. A sense that something that had been riding slightly forward had settled back. I'll be careful here. This was a single self-observation, and I am the least reliable narrator for my own physiology. I'd been thinking about the chain for weeks at that point. Expectation bias is real. But I've also spent enough time in clinical assessment to know the difference between something I talked myself into noticing and something that genuinely surprised me. This surprised me. So I went back to the anatomy. And what I found, following the anterior arm fascia up through Stecco's dissection maps, through the cervical investing fascia, to the periosteal attachments at the temporal and zygomatic regions, was that the structural basis for what I'd felt was there. The surprise wasn't a placebo effect, it was an anatomy gap. I'd known the chain intellectually and hadn't traced it to that conclusion clinically. That's when I started integrating the forearm unlock into anterior chain assessments as a before and after reference point. Not as a standalone facial treatment, as a window into how much of the patient's anterior chain tension was carrying into the cranial region. Which brings us to the verdict and how to apply this based on your specific situation. The verdict. The 90-second forearm unlock is anatomically well-grounded, mechanistically specific, and clinically underutilized. The claims about facial structural change are partially supported. The mechanism is sound, the immediate soft tissue effect is plausible and consistent with fascial anatomy, and the self-observation evidence, including mine, points in a consistent direction. The large-scale outcome evidence specific to facial structure is not yet robust. That's the honest position. For most people reading this, the protocol is worth doing, not because it promises dramatic facial transformation, but because it addresses a genuine anterior chain loading pattern that affects far more than the face. Here is how to apply it based on where you are. If your primary pattern is forearm flexor dominance from device use, typing, or carrying, and for most people in the 50 to 75 range, this describes you. The standard release is your starting point. Sit or stand with good spinal position. Extend one arm in front of you, palm facing the ceiling, full supination. Bring your wrist into extension by letting the back of your hand drop toward the floor, fingers pointing down. The elbow should be extended, but not locked hard. You're looking for a sustained pull along the inner forearm from wrist toward elbow. Hold this for 90 seconds per arm. Breathe normally. Don't hold your breath into the stretch, because breath hold increases anterior chain tension through the diaphragm and defeats the release. Notice any change in jaw tension or cheek heaviness after completing both arms. That noticing is diagnostic, not placebo. You're reading your own chain. If you have wrist or elbow pathology, lateral epicondylitis, wrist impingement, carpal tunnel symptoms, do not go to in-range extension. Take the wrist to a comfortable midpoint, a 30-degree extension rather than 60 or 70. You're still loading the anterior fascial chain without stressing compromised structures. Duration is the same. The release may be less pronounced, but it's still real. If you have hypermobility, if your joints move well past typical range, if the phrase double jointed has applied to you, do not take this to in range in either direction. Fascial release protocols for hypermobile tissue operate differently. For this population, a very gentle, sustained midpoint hold, 15 to 20 degrees of wrist extension with neutral forearm rotation rather than full supination, held for the same 90 seconds, is the appropriate protocol. The goal is activation of proprioceptive awareness along the chain, not end range loading of already overstretched tissue. For all three populations, morning is the optimal time before the day's loading accumulates in the flexor compartment, before you've opened your phone, before the first grip of the day. The forearm tissue is relatively hydrated and pliable after sleep. The release propagates more fully. Think of it as setting the anterior chain's resting length before the day sets it for you. What keeps coming back to me after years of working with fascial anatomy is how consistently the body defies compartmentalization. We learn anatomy in segments, the forearm chapter, the cervical spine chapter, the facial anatomy chapter, and somewhere in the process, the thread connecting them gets obscured by the chapter breaks. That thread, the actual collagen thread running from palm to cheekbone, doesn't care about how we organize the textbook. It transmits tension according to its own architecture, which is older and more elegant than any curriculum. The reason this protocol keeps surprising clinicians who encounter it properly isn't that it's exotic. It's that it works along a structural line that formal anatomical education left unemphasized. Thomas Meyer's contribution was not discovering new anatomy. It was following the thread all the way to the end. The people who take this most seriously are those who've developed the habit of asking where a structure goes, not just where it starts. They're not satisfied with the forearm as a forearm. They want to know what the forearm connects to. And from there, what that connects to. And from there, how far down the chain an intervention at one end ripples. If that's the question you carry out of this review, the anatomy will keep rewarding it. There are other chains, other release points, other places where an arm or a foot or a rib cage is quietly governing something at the face and nobody has told you yet. Subscribe and stay close, because that's exactly the kind of structural investigation this channel is built for.